let's talk about hyponatremia. You know, it's one of the most common and, frankly, one of the most challenging problems we face. So in this explainer, we're going to put on our detective hats and really walk through the clinical work needed to get the diagnosis right, especially in these tricky cases. Let's get started.
So we're jumping right into the deep end. We've got a 47-year-old man, he's symptomatic, and his sodium is a shocking 112. This isn't just a number on a lab report, this is a patient in real trouble, and what we do next is absolutely critical.
And make no mistake, this is not some rare, esoteric problem. We see this all the time. Hyponatremia shows up in more than 15% of hospitalized patients. It is, by far, the most common electrolyte disorder we manage. That's exactly why having a sharp, systematic approach is a must.
Okay, let's get back to our patient. He's in crisis, clearly. Let's break down these initial labs, because they're our first real set of clues in this whole diagnostic puzzle. What are they actually telling us?
This is just a crucial slide. We have 3 key pieces of information here. 1. Severe hyponatremia. 2. The low serum osmolality confirms this is true hypotonic hyponatremia. And 3, and this is so important, on exam he's euvolemic. No signs of fluid overload, no signs of dehydration. This specific triad really sets us on our path.
So how do we use these clues? Well, the real key to cracking this case lies in understanding the relationship between what's happening in the plasma and what the kidneys are doing with the urine.
That serum osmolality of 238 really cements it for us. We're squarely in the hypotonic category. This means it's not some lab artifact, not a pseudo-hyponatremia. No, this is a genuine problem of water balance. The body simply has too much water for its amount of salt.
And this is where it gets interesting, because there's a paradox here. Normally, when your body is waterlogged like this, your brain should shut off antidiuretic hormone, or AVP, right? The kidneys should then kick into gear, pump out tons of dilute urine, and fix the problem. But our patient's urine is concentrated. The kidneys are holding on to water when they should be dumping it.
This exact situation, a dilute body but concentrated urine, is the textbook signature of SIAD. It tells us that AVP is active when it absolutely should not be. So SIAD rockets to the top of our differential. But, and this is a big but, we can't just stop here.
Because here's the thing. SIAD has to be a diagnosis of exclusion. There's another condition out there, a dangerous mimic, that can look exactly the same. And missing it, well, that could be a disaster.
Just look at this side by side. It's kind of scary, right? On the surface, secondary adrenal insufficiency is a perfect doppelganger for SIAD. You get the same euvolemic, hypotonic hyponatremia, the same concentrated urine. Why? Because a profound lack of cortisol can also drive AVP release. It's a perfect mimic.
Which leads us to this pivotal question. Knowing what we know now, understanding this dangerous overlap, what's the single most important lab test you need to order, right now, to tell these two apart?
And the answer is, without a doubt, cortisol. Yes, thyroid function matters, but the immediate, life-threatening condition you must rule out before you can even think about calling it SIAD is adrenal insufficiency. Period.
And here is why that step is non-negotiable. Our patient's morning cortisol came back at 0.76, critically dangerously low. This wasn't SIAD at all. It was severe secondary adrenal insufficiency. Imagine if we had treated this as SIAD with fluid restriction while he was desperately starved for steroids. A catastrophic error.
This case perfectly illustrates why a strict diagnostic checklist for SIAD is so important. It's not just about finding things that fit. It's about systematically ruling out the things that can kill your patient.
So, let's look at that checklist. This is how we do it right. First, confirm hypotonicity. Then, make sure the urine is inappropriately concentrated. Assess for euvolemia. Check that urine's sodium. But that 5th step, that's the gatekeeper. You cannot land on a diagnosis of SIAD until you have confirmed normal adrenal and thyroid function.
Okay, so let's imagine a different scenario. Let's say you've done all that. You've excluded the mimics, and you've definitively diagnosed SIAD. Well, the detective work still isn't over. Now you have to figure out why. What's the trigger?
And the list of potential culprits is long. It could be anything from a CNS issue or a lung problem to an underlying cancer. But you know, one of the most common things we see? Medications. You have to comb through that medication list, looking for things like SSRIs or certain seizure meds.
Post-op states, especially after neurosurgery, are another classic trigger. And what's really important to remember here is that it's often delayed. The sodium doesn't just crash on day 1, it can happen a week or even 2 weeks later, which is why we have to be so vigilant in those patients.
So you see, by following this very structured, logical path, confirming the basics, evaluating the urine response, and then, most importantly, rigorously excluding those critical mimics, we can get to a diagnosis that we're confident in and one that's safe for our patient.
Getting the diagnosis right is a massive win, but it's really just the first half of the story. The next big challenge is management. How do you treat this safely and effectively? That opens up a whole other can of worms with its own risks and debates. And that is exactly what we'll tackle in part 2.